Hello everyone. Today's topic is exploring beliefs and perspectives in relational practice. We will get a jump start on topic 5 today and follow up at the end of next week with our subsequent virtual classroom experience, looking at the topics of cultural safety and the culture of poverty. So today we will zone in on the belief systems and how varying belief systems impact our practice in nursing, as well as various lenses or perspectives that inform the way we view our work with families and how we engage in clinical practice. Now, when talking about beliefs, I want to define what beliefs are. Beliefs are lenses through which we view the world, guiding the choices we make, the behaviors we choose, and feelings with which we respond. Beliefs reflect who we inherently are and how we present ourselves in our relationships and to the world. So you can see that when you reflect on beliefs, they really do inform our ways of knowing, being, and doing. Beliefs are very subjective, they pertain to the individual, and they're continually evolving. It can be difficult to pinpoint what beliefs you hold, and so therefore this really speaks to the importance of self-awareness and growing that self-awareness in practice. So through continual reflection on various client-family encounters you have in practice, try to define and really pinpoint those underlying beliefs that might be at work there, because there's two different types of beliefs that we can classify them in according to those beliefs that are constraining, those beliefs that really hold a person back and prevent further growth, and those beliefs that are facilitating, those beliefs that really prompt self-growth and are positive and helpful to the individual. So it's important to examine our beliefs, know that they are continually evolving, and that depending on the experiences we have, we can reflect on whether those beliefs are serving for us or against us. And beliefs are determined by our biopsychosocial spiritual makeup. So again, that speaks to how beliefs are very individual and are defined by the individual and informed by our own unique experiences in life. Now, we just spoke about constraining and facilitating beliefs, and I want to give you an example to make this more understandable. So, for example, if one of your clients expresses that she is not good at anything and has no hobbies or interests because she does not feel she can do well at anything, this is a depressive thought, but also reflective of an underlying belief that she has no ability or talent and is inadequate. So there's this deep entrenched belief there that really underpins that depression. This belief will affect her differently from the individual who is self-determined and confident, who holds the belief that there is nothing they can't do. So you can see the dichotomy between beliefs that are challenging and those that are facilitating, how our beliefs can either hold us back or help us grow. And really defining the beliefs that are at work in our clinical practice can help serve and inform that therapeutic relationship, because we can explore that with our clients, those beliefs that are constraining or facilitating. So now in looking at examining beliefs, I want you to take a few minutes to reflect on the following. Are you aware of your own beliefs in varying situations? We know it can be very difficult to identify the beliefs at work in our daily practices. So it really is helpful, I find, to question yourself around your own definitions of patient. Who do you believe your patient to be? Who do you believe the family to be? What is their role in the care of an individual? What is your definition of illness? What is your definition of change? And how is change able to be achieved in clinical practice? So by looking at various definitions you have in your work as a nurse, you can really examine those underlying beliefs, because your definitions reflect those beliefs. You know, what you believe to be true, really, about families, about illness, about change, about healing and health promotion. So really ask yourself those critically oriented questions, and then look at how you respond in particular stressful situations. The actions that you take reflect underlying belief systems. What you deem to be the most important response in that situation often reflects an inherent, innate belief that something is of primary importance, that this is the way you have to respond in this situation. So also look at your words in addition to your actions and try to identify those underlying belief systems. So for example, when we look at the words that we use, if we talk about diminishing, reducing, or alleviating suffering in our work with families, that really pertains to and speaks to the belief that we can measure suffering. We can measure it by the way that we're describing it. But really, can we measure suffering? Suffering is such a unique human lived experience that we can seek to understand it, but can we truly objectively measure it? And that is an impossibility. So a better word to use would be softening suffering. Now this is a term that is just growing in awareness, and it speaks to the need to understand suffering through the unique lens of the person experiencing it. So we cannot assign a value system to the suffering, but really just seek to understand it in all of its complexity as it pertains to the individual in the context of their own life. Another example is person-centered language versus pathologizing language. Now, pathologizing speaks to pathology or illness, where we give primacy to the illness. And we can see the language we use really reflects underlying beliefs. For example, if I use the language person with a disability, you can see I'm giving primacy to the person, the individual. I'm not saying disabled person. That would put the illness first. So really the way we describe things has meaning, and we need to really look at our own belief systems and how they are being conveyed through the words that we use. Let's look at a case here and the underlying beliefs at work. So a client with refractory schizophrenia informs a family member that he is having pain all over his body and that he has never experienced this before. His family member doubts that he is actually experiencing pain and tells him it's all in your head. So what beliefs underpin this statement? This individual here, because he has a pre-existing mental illness, this is informing the family member's response. So the family member is working from the belief that this individual cannot be taken seriously because of their mental illness. And therefore, the mental illness present is clouding the family member's view of the client's pain symptoms. We could also see this case as an example of the Cartesian view of illness, because the focus is just on the mind, just on the mental health symptom of these schizophrenia symptoms at work that have been difficult to treat. And so any kind of bodily reports of experiencing pain are denied and suppressed because the mental illness is really given primacy here. So we can see in this situation that we're not identifying what the pain is like, the subjective experience of that pain, what increases the pain, what diminishes it, when did this pain occur. We're really limiting our understanding of the pain experience. And so you could imagine in the context of our clinical work with clients and their families, how this type of approach, in this case example, could really cloud our own view and our own ability to care for a client. Now here is a quote that I found interesting and really speaks to how difficult it is to identify and challenge beliefs that have long been held and have become habitual. So here's the quote: "It is hard to let old beliefs go. They are familiar, we are comfortable with them, and have spent years building systems and developing habits that depend on them. Like a man who has worn eyeglasses so long that he forgets he has them on, we forget that the world looks to us the way it does because we have become used to seeing it that way through a particular set of lenses." So this quote to me really speaks to how important it is to be flexible in practice, flexible in the viewpoints you take, and challenging those viewpoints or perspectives so that you take a step back and reflect on, what are you seeing here? What are you giving the most importance to in this situation? What are your beliefs that are informing your actions in a particular situation? So really adopting a critical lens can help inform the care you provide in nursing practice. So now we come to the critical perspectives or lenses. All of these perspectives that are critically oriented are concerned with power and social context and really challenging the status quo. So we can view families from different varying perspectives and lenses. And really the critical lens helps us challenge ways of being, knowing, and doing. And we're going to examine that in the following slides. The critical lens involves three overlapping perspectives that we'll talk about: the feminist lens, the post-colonial lens, and the post-structural lens. Now, I'm referring you to the Duane and Varco text, which is part of your in-prep reading, and on page 62, box 2.2 has a list of all the assumptions and ideas related to a critical lens, and that will assist in helping you understand this particular viewpoint better. The feminist lens looks at how power is gendered, the gender roles and inequalities that exist in society, and how roles are socially constructed. So when you look at the nursing profession, for example, the majority of nurses have been women over time. However, there has been a more openness in the profession to accept males and invite males to join in nursing education programs and within the profession. Women as caregivers, that also looks at how women are gendered in their role as caregivers, and there are particular expectations for women to fulfill this caregiving role, and so that can also be viewed through a feminist lens. I have an example here from public health nursing practice that can be looked at through a feminist lens as well, and I'll share this with you. So a public health nurse decides to phone a family after she receives the discharge papers, and it's 48 hours after the family's been discharged from the hospital. The mother's just given birth to her newborn, and the public health nurse wants to do the postnatal assessment. So when the public health nurse phones the family, she gets the father and she speaks to him, asking if she can speak with his wife, as she has a few questions to ask in follow-up. The father states that his wife is sleeping, and the public health nurse then states she will call back later. She abruptly ends the call. So what is being missed here? The public health nurse's response indicates a lack of interest in the father's perspective and experiences, and the public health nurse thus missed out on key information the father could share about the newborn care and adjustment post-discharge. This reflects a gendered response to family assessments in which the mother's experiences are privileged over the father's, and how nurses can perpetuate gender roles through the assumptions they make around particular family members' roles and responsibilities. Now, the post-colonial lens addresses the social conditions impacted by colonialism, and colonialism speaks to the process in which a foreign power, usually European powers between the 16th and 20th centuries, dominated and exploited indigenous groups. Now, racism is a constant companion to colonialism in the way that the colonizers viewed and treated the indigenous peoples. And you can see that through some of the descriptors they would use, such as backward, savage, less civilized than the colonizers, and in need of taming, education, or civilizing. That's an example of racism, where the colonizers were exerting their domination and oppression over those who were vulnerable and those they saw as less than. And so this can have negative impacts on populations that we work with because of that history of colonization. And the post-colonial lens really draws attention to how people have been and continue to be marginalized by colonialism and racism, how that continues to exist today and really transfers to the present from the past. The post-colonial lens also engages in a purposeful examination of colonialism as it existed and continues to exist locally and globally. I have an example here to share with you from page 69 of the Duane and Varco text, which is assigned reading for topic 5 of this week. And it describes a group of nurses in a remote community who recognized very high rates of cervical cancer among Aboriginal women. They discovered the women were not having their pap smears done routinely, and rather than adopting a finger-wagging, blaming sort of approach in which they really blamed the women for not engaging in a health-promoting procedure, the nurses realized that given the history of the church school in the area, many of the women may have been sexually abused, and that could limit their participation in pap smear exams. They also considered the history of race relations in the community was not conducive to building trust between Aboriginal women and the predominantly white nurses. So there wasn't the best fit there happening between the nurses as health providers in the community and the Aboriginal women population. So the nurses sought the input of female elders and offered a women's clinic where pap smears were only suggested as a possibility after dealing with a range of other issues the women raised. The elders acted as healers and supporters during the pap smear exams, and although some women continued to decline those exams, the number of women who did engage in the exams tripled within a year. So it did have a positive impact. So you can see in this example that the nurses adopted a post-colonial lens in which they understood the issue through some of the historical processes at work and looking at the current relationship between the healthcare providers and the population who is experiencing these high rates of cervical cancer. And certainly, if the post-colonial lens was not adopted, the issue could have been located within the individual, and so blame would be assigned to the individual for not engaging in a health-promoting behavior. And so that would definitely impact the ability to build trust and rapport with the population here in this case scenario. And the therapeutic relationship, therefore, would not develop. Now, the post-structural lens looks at how language creates social reality and how language shapes experience, gender roles, and family. So language really plays an active role in bringing forth what is real, what is considered true. And we can look at the way in which others language their experiences and really challenge any dominant ways of languaging or those dominant discourses, as it were, that are present in the health conversation. So if we notice, for example, that a family is perpetually describing themselves as a victim rather than a survivor, that perhaps a family member completed suicide and they're viewing themselves as victims of that, that this was something horrible done to them and they're suffering as a result of it. So instead of viewing themselves as victims, we can work with families to look at a more helpful, facilitating way of really speaking their experience into existence. So using the language of survivorship, being survivors of that challenging experience that brought forth suffering, that can be more of a helpful, useful tool long term as compared to victims, which really conveys a passive role, something done to somebody else, and that creates the victim perspective. Survivor gives a message of hope and really striving to live on after experiencing a struggle or challenge. Now, some other examples of how language creates a particular reality or experience includes the description of patients as consumers of healthcare. So that label of consumers really influences the way we view patients. In addition, describing clients as frequent flyers might create more of a dismissive response by healthcare providers to those that are continually in and out of the hospital and drawing upon healthcare resources. So I'm interested if you can identify any other common language descriptors in healthcare, ways of languaging experiences in healthcare that could be examined through a post-structural lens. Now, I'd like to direct you to read the case study posted to Blackboard and, in addition, the Topic 5 worksheet posted to Blackboard as well. So the worksheet really explains the different perspectives you can take when assessing a certain situation. And the worksheet is really a cheat sheet for understanding those various perspectives that we talked about in this PowerPoint. So I want you to adopt the different perspectives lenses outlined and write down how you would view the case according to those unique perspectives. So ask yourself, what would you focus on if, for example, you adopted a post-structural perspective, or maybe a post-colonial, feminist, or Cartesian perspective? So work through those 4 different perspectives, and I invite you to post your answer on the discussion board on Blackboard, so that will really get the discussion going. I think it would be really rich learning so that we can learn from others and how we can understand unique cases through the various lenses that we adopt.